Good morning, good afternoon, and good evening to all from wherever you are joining us here today. On behalf of Retina International, I would like to extend to you my warmest welcome to today's panel discussion, where we will explore the key findings and implications of our new IRDCounts study, which evaluates the cost of illness of IRDs in the US and Canada. My name is Fiona Waters, and I am the Community Engagement and Outreach Officer here at Retina International. We are thrilled to be welcoming so many of you today. Thank you so much for registering and attending. We are very excited for the discussions yet to unfold and for the opportunity to shed a light on the full picture of what life with an IRD can be like. We're truly thankful for the support of our partners in this study, namely Foundation Fighting Blindness and Fighting Blindness Canada, both of whom are represented here today on our panel. And of course, our industry partners, AGTC, Janssen Global, and Novartis Pharma AG. Moderating our panel today is Dr. Orla Galvin. Orla is the Director of Research Policy here at Retina International and has played a pivotal role in this US and Canada cost of illness study. Joining us on the panel will be Doug Earle, CEO and President of Fighting Blindness Canada. Following Doug will be Dr. Todd Durham, Vice President, Clinical and Outcomes Research at Foundation Fighting Blindness. We will have Allison Galloway, who is perfectly on time. Allison will be bringing the patient voice today as a patient-parent advocate. And last but not least, we have Dr. Rob Koenekoop from Montreal Children's Hospital, who's bringing the clinical perspective to today's discussions. Each of our panelists will give a short presentation, and this will be followed by a discussion and Q&A session. We encourage you to ask questions for our panel today. If you wish to ask anything, please send your query by email to registration@retinainternational.org. I will share the address on the screen now, just so that you can see it. Okay, so please note that we are not using the Zoom chat and Q&A function today, as it is not accessible to all. So I will just repeat the email address again. It is registration@retina-international.org. So please do email any questions for our panel to that address. Without further ado, I am delighted to introduce Dr. Orla Galvin. Orla is the Director of Research Policy here at Retina International, where she oversees the day-to-day running of research, education, and advocacy programs. This study is the second in our suite of IRDCounts studies, both of which have been spearheaded by Orla and included her leading a consortia of patient organizations, clinicians, and industry partners to develop cost of illness studies for the inherited retinal disease population. Orla is hopeful that with access to treatments and improved care pathways, the burden measured now will be greatly reduced in years to come. And with that, Orla, I will hand over to you.
Thank you so much, Fiona. Take a second for the slides to appear.
Whenever you're ready, Orla.
Thank you. Next slide, please. So as Fiona mentioned, we have a suite now of cost of illness studies. And I'm conscious that there is a vast and diverse audience with us today. So the rationale for conducting these studies was that there were a number of gaps surrounding the knowledge of inherited retinal dystrophies. and there was an absolute lack of published data for IRDs. So that's the why. And if you'd like to know what cost of illness studies can be used for, they can of course be used for inputs to economic analysis, for the justification of investment in preventative or treatment interventions, and of course for service provision. Cost of illness studies can be used to inform funding allocation and prioritisation, and to provide a basis for policy and planning. If you would like to have access to any of these with a one-stop shop approach, you can of course visit the website that is on the top of your screen at the moment. That's retina-kyc for knowyourcode.org, and you'll find the full suite of cost of illness studies there. The two on your left are from the original pilot study in the United Kingdom and Republic of Ireland, which focused on 10 IRDs. And the two on the right are those most recently published, and they focus on 14 IRDs. And if the screen could not make it any more clear, all of these were only made possible because they were made in conjunction and cooperation and collaboration with patients and with caregivers. Next slide, please. So as I mentioned, the original study focused on 10 IRDs in the UK and the Republic of Ireland, and they were retinitis pigmentosa, Usher syndrome, Stargardt disease, Leber congenital amaurosis, Best disease, cone dystrophy, cone rod dystrophy, achromatopsia, X-linked retinoschisis, and choroideremia. In the more recent study in the USA and Canada, all of the original pilot study conditions were included. As well as this, the following conditions were included: Bardet-Biedl syndrome, Leber's hereditary optic neuropathy, rod cone dystrophy, blue cone monochromacy, and owing to the large population size, we were fortunate enough to be able to also include a breakdown of retinitis pigmentosa to include autosomal dominant RP, autosomal recessive RP, and X-linked RP. Next slide, please. At this point, again, I would like to reiterate a huge thank you and the essential participation of those individuals who were involved with all 4 studies. Essential to these studies was the input from those living with IRDs and the parents and guardians of children living with IRDs. There were 129 individuals across the UK and the Republic of Ireland who participated in the pilot study, and 843 individuals across the United States of America and Canada who participated. And it is their data, supported by a literature review and inputs to a cost of illness model proprietary to Deloitte, and that was based on a prevalence approach that allowed us to have this data. Next slide, please. So for the next few minutes, I'm going to share with you some top-line comparisons between the pilot study in the Republic of Ireland and the UK and the more recent study in the USA and Canada. In the pilot study, total costs for 10 IRDs for a single year reflected £523 million in the UK and €49.5 million in the Republic of Ireland. By comparison, in Canada and the USA, reflecting 14 IRDs for a given year, this resulted in 1.6 billion Canadian dollars in Canada and up to $31.7 billion US in the USA. In all 4 studies, it has been shown that the individuals themselves and their families bear the vast majority of these costs. Next slide, please. As you can see in the United Kingdom, individuals, family and friends bear the greatest cost burden with 36% and 21% respectively. In the Republic of Ireland, individuals bear 51% of this cost, with family and friends bearing 16% of this cost. In Canada, we see that individuals bear 80% of this cost, while friends bear 7% of this cost. In the United States of America, we've seen that individuals bear 75% of this cost, and family and friends bear 6% of these costs. Next slide, please. Of greatest concern to all of those who have already seen the data is that the greatest cost type is in fact well-being. We've learned in the pilot study in the Republic of Ireland and UK that this amounted to approximately 1/3 of the total costs in each region. In the USA and Canada, this has amounted to approximately 2/3 of the total costs. The majority of all survey participants report high levels of anxiety and depression. If you look at your screen now, you'll see across all regions, if we look at anxiety, we have 85% reported in the Republic of Ireland, 86% in the UK, 76% in the US, and 84% in Canada. Depression is the next highest well-being factor impacted, with 63% in the Republic of Ireland, 67% in the UK, 61% in the USA, and 74% in Canada. I think this year is the first year we're all really truly getting to understand what social isolation really means. And we can see again that across the board in the Republic of Ireland, this is reported 44% of the time, 56% in the UK, 36% in the USA, 48% in Canada. Another striking impact is the financial stress. And again, across the board, we see that this is 43% in the Republic of Ireland, 45% in the UK, 34% in the USA, and 55% in Canada. Next slide, please. The well-being impacts do not only affect those living with IRDs, but also the parents. And as we can see from those who participated in the survey, anxiety and depression were also greatly reported. We see anxiety reported 75% in the Republic of Ireland, 77% in the UK, 71% in the USA, and 84% in Canada. Again, this was followed closely by depression, which was reported 50% in the Republic of Ireland, 77% in the UK, 53% in the USA, and 61% in Canada. But what I want to take you back to right now is that impact of financial stress. And we see that 43% in the Republic of Ireland, 45% in the UK, 34% in the USA, and 55% of those living with an IRD report this financial stress. So we might ask ourselves why, and on the next slide, we will be able to get some appreciation for that. The second greatest cost type is, of course, the productivity costs, and this was reflected in all 4 studies. Productivity costs, or rather productivity losses, are costs relating to participation in the workforce. So we have learned that in the Republic of Ireland and the UK, people living with an IRD were 55.7% and 40.2% respectively less likely to be in paid employment than the general population. In the USA and Canada, this was slightly better in that people living with an IRD are 28.8% and 24.4% respectively less likely to be in paid employment than the general population. And in financial terms, the value of that reflects €9.4 million in the Republic of Ireland for a given year, £114.1 million in the UK, $4 billion in the USA, and $205 million in Canada. And where the vast majority of this comes from is the proportion due to foregone income as a result of reduced workforce participation. So we learned that 74% of the 9.4 comes from that in the Republic of Ireland, 78% in the UK, 88% in the USA, and 72% in Canada. And this is of great concern to the IRD community. Next slide, please. Another striking similarity across these studies is that very low percentage of total costs that are reflected by health system costs. And this is a huge concern. And it shows across all 4 studies that processes for reimbursement of therapies for the IRD community are completely inappropriate. All 4 studies show that the health system costs are extremely low and represent only 4.5% of total costs in the Republic of Ireland, 4.8% of total costs in the UK, 7.2% of total costs in the USA, and 2.3% of total costs in Canada. Therefore, clearly, they do not reflect the true cost of living with an IRD. Next slide, please. One of the most important things that is brought up to patient organisations is the importance of an accurate diagnosis. And if we look at the present study in the USA and Canada, we learned that 62% of survey respondents in Canada indicated they received a genetic test for the purpose of diagnosing their IRD. And of these, only 22% indicated that a family member also received a genetic test. In the USA, 77% of survey respondents indicated they received a genetic test for the purpose of diagnosing their IRD. And of these, only 28.2% indicated that a family member also received a genetic test. So with that, I would like to open a discussion to our panelists and perhaps reflect on what the impact of the cost of illness study data has meant to them, and also what the impact of a diagnosis, an accurate diagnosis, can mean to their communities. So firstly, Doug, I'll bring this to you.
Great. Thank you, Orla. If we could put the first visual up, please. And you can start my video if you want as well. So I just wanted to reflect on some of the Canadian numbers and what it does mean to people living with inherited retinal diseases in Canada. So first off, Fighting Blindness Canada started 2020 with this very special moment in time, as that lab discoveries are making the transition into now clinical trials, into the clinics with new treatments and new opportunities for actually being able to go from a diagnosis to actually having a viable treatment. And in Canada, we're celebrating the first gene therapy to be approved by Health Canada that is targeting a gene that does affect an inherited retinal disease. And so now this is reality. So in starting our this very special 2020, of course, symbolic year for vision, we embarked on a number of key elements to be able to influence public policy so that we can improve our healthcare and improve the quality of life of people living with inherited retinal diseases. So first, we held a summit with our vision partners. We surveyed over 300 key opinion leaders, people living with vision loss, caregivers, healthcare professionals, and researchers. And we published from this summit in February 3 white papers to give voice to the community and the challenges and the issues that we were bringing forward to the decision makers in government and trying to influence public policy. With this first gene therapy, we did launch right in the middle of COVID a quality of life study in order to submit to the government agency that makes the recommendation to our provincial governments to fund this study or to fund this treatment. And we're very pleased that 537 members of our community responded. And then the third, we worked with a vision partner to develop a survey and understand the impact of COVID, especially and its exasperation of what has been found in IRDCounts. And then, of course, this release in October of the social economic study, the IRDCounts for Canada. And I want to talk around what this $1.6 billion estimate is attributable cost to living with an inherited retinal disease. And this for Canada is the first time that we've had an ability for the inherited retinal community to be able to put a value, an economic impact value for what it means living with these conditions. So when researchers like Dr. Koenekoop and his colleagues fill out the very first question in that research application What is the impact of the research that you're doing? This is now the study that they can point to talk about those consequences and in the importance of this research and importance of what it means living with these conditions. And if the next slide, and when we look at the breakdown of what those costs are, I think it does say something about the Canadian healthcare system, and that's where we do need to focus on enhancing and having conversations with our public policy decision makers. When you look at this, what is the cost of illness and what are the breakdown, with well-being being 66%. And that is actually the first time in Canada that a value has been given to well-being, and it's $1.1 billion cost. And the real tangible voice or demonstration of what anxiety, depression, financial stress, social isolation happens. And I did want to sort of speak to this directly, and especially with the COVID impact of COVID and the survey that we did with our vision partner, the Canadian Council of the Blind. And I want to quote one of the participants who said, quote, "What is affecting my mental health during COVID is this prolonged and extreme isolation. As a blind person, I already live a fairly limited life when referring to the freedom of movement and independence. And now even that small wedge of an active life has been completely eradicated because of COVID." So in this period, in giving voice to, because of this study, we are living under this very jarring experience of COVID, where touch is such a important part of navigation, and that creates heightened anxiety around the spread of the virus. In the survey that we found, the support systems that are in the Canadian community have been experienced. Well over half of the people experienced a loss of those services, and real practical experiences around trying to cross the street, being able to navigate in grocery stores, that COVID has just compounded what was found in this study, and a real challenge for people as they're navigating. Other quotes around some of the productivity loss, which was found to be about 13%. Great. Someone was quoted in our survey telling us that they had to quit their master's education program because they couldn't keep up with the technology barriers that were compounding their learning. They had to leave a job after 16 years because they couldn't navigate that job anymore. And it's been a tough slog, was the quote, since then, with the economic ability to earn an income. The required assistance to technology to complete my job is the software packages don't accommodate that technology. So my employer had to rearrange the work that I was doing. And some of the real stigma that happens is captured in this well-being, with another quote that we got from our survey around taken out of gym in high school, and the stigma that caused because of living with an inherited retinal disease and not able to participate in those activities. These are real, and for the first time in Canada, we have an economic value attached to it. Around the other side, the more traditional side of doing economic modeling, productivity loss and the ability to earn an income. In the survey, IRDCounts, I think one of the most telling stats was 24% of the people responding were less likely to have employment than their sighted colleagues. And I think that does have an impact on quality of life. And of course, being on disability, our pension disability, the CPP disability allowance, are definitely impacting the quality of life and having an economic impact. Informal care borne again by individuals, not a part of the formal health system, and where only 2% of the cost of illness is borne by the healthcare system directly, 38 million of that 1.6 billion. And I think that says an awful lot around where people are finding what is the cost of illness and how they are able to access the services, is that this is largely borne by the people living with these conditions and their families. And this is why, for us, as we're trying to build our case for advocating to key policy decision makers, that new treatments, better services, better access to care and support services, better support services for families, trying to develop those services around reducing anxiety, depression, the financial stress, social isolation, that this study will be and is already an invaluable tool to us as we talk with policymakers to develop and improve our healthcare and social support systems within Canada. So for us, this is a landmark study. It is helping us advocate for more clinical trials coming to Canada, so people have access to care directly at the earliest possible moment, that they are able to access new treatments quickly, which is a very significant issue as regulatory changes are being considered by our federal government around that could have barriers to accessing these innovative treatments. And then having real, as we're challenged with the cost of healthcare and making the system sustainable, with discussions around the gene therapy and other new treatments, that they are publicly funded so that there is no economic barrier to accessing new treatments. And this study will play a very significant role in helping us be able to communicate to public policy decision makers what is the impact and what they will do to help us, because a lot of the decisions are based on impact on healthcare. And of course, with inherited retinal diseases, with so much of it borne by the family, this study gives us the facts that we need in order to advocate. And I encourage the community to visit fightingblindness.ca. You can look at our help advocate, get involved, health advocate subdirectory. So under the main menu around get involved, and then under help advocate, you can see our submission to encourage public funding of the first gene therapy, our white papers giving voice to the community, our drive for research, living with the condition and access to healthcare, and the IRDCounts Canada is there with your links, and also opportunities on our website to share your story so that we can help inform those decision makers to help improve our system, and also to approve these new treatments and access to these new treatments as quickly as possible. So thank you. I look forward to your questions.
Thank you very much, Doug. So that was Doug Earle, who's the President and CEO of Fighting Blindness Canada. Thank you very much. Next, I am delighted to introduce to you Dr. Todd Durham. So Todd is the Vice President, Clinical and Outcomes Research at Foundation Fighting Blindness, which is a national US nonprofit that funds research to treat and cure inherited retinal diseases. In his current role, Todd is responsible for directing the Foundation's clinical consortium of retinal experts, developing strategies to enhance product development, partnering with industry, and providing technical input on partnered programs and investment decisions. We extend a very warm virtual welcome to Todd, and I will open up your video now.
Thank you, Fiona. Thanks, Doug, for those comments. I would also like to thank Retina International for leading this project and thank our other consortium partners, AGTC, Fighting Blindness Canada, Janssen Global, and Novartis. It's really nice collaborating with all of them. I wanted to recap a bit about what this study is about, both in terms of its methods and its objectives, but then its results and how we think about what this study means for our community. Cost of illness studies are important because they help us understand how diseases impact society as a whole. They can help us prioritize policies and interventions like the treatments we're pursuing so that they have the greatest societal impact, and they can be used in formal economic assessments of these new therapies, like cost effectiveness studies. When you read through the report, you realize that the cost can come from various sources, including healthcare utilization. This would be things like hospital visits or use of prescription drugs. It can come from productivity loss because someone left the workforce maybe sooner than they thought, or maybe they took a lower paying job than they would have otherwise had it not been for their IRD. Productivity loss can also come from missing days at work for the job that you do have. And there are also costs incurred by caregivers who are taking care of family members with IRDs. The overall approach of this study, like others who used a similar methodology, was first to estimate the prevalence of the inherited retinal diseases, describe and tabulate those diseases by their particular condition, so like retinitis pigmentosa, for example, Stargardt disease, and then collect primary data meaning from the survey which we distributed to our communities, collect data on the cost drivers, those things that we can attribute cost to, and then assign cost to the cost drivers that we collected from the survey. And these costs come from published data from healthcare providers. You may need to use some assumptions in some cases. And then you sum all these costs up. Wanted to also remark, when you read through the study, including the executive summary, you'll see that the research team expressed estimates of cases, that is individuals with IRDs in the US, using both lower and upper bounds. And this use of lower and upper bounds really expresses our uncertainty about the true numbers of cases. In the cases of inherited retinal diseases that require a genetic confirmation, estimating prevalence can be tricky because we don't have large population-wide studies with that genetic component. Instead, we have cohorts from individual centers around the country where individuals are seen for care. But in any case, the research team at Deloitte approached this part of the study in a couple of ways, and those two approaches give us the lower bound and an upper bound on the number of individuals in the US with IRDs. Now I'd like to spend a few minutes talking about the results from the US study. The Foundation Fighting Blindness distributed the survey link to approximately 8,000 members of our registry called My Retina Tracker Registry. This registry is designed and operated to help match members of our registry with potential research opportunities, which could include a study like this, but many hope that they will be matched with a clinical trial opportunity. And this registry also gives us the ability to gain some insights about disease progression. And because we have genetic test results from many of our members, we can also learn about the prevalence of specific disease-causing variants. From our survey distribution, we had 687 respondents. And the most commonly reported clinical conditions were retinitis pigmentosa, reported by 50%, Stargardt disease, 12%, and Usher syndrome, 11%. 43% of the respondents reported they were legally blind. 77 reported that they had a genetic test. Now, a bit about the results having to do with the cost drivers. The respondents reported that 57% of them saw an ophthalmologist in the last year for an average of 2 times. 40% saw an optometrist or optician for an average of 2 times. 26% saw their PCP for an average of 2 times. And as you've already heard, the role of mental health is quite substantial in this study, and we see that 11% of our respondents reported seeing a psychologist or psychiatrist an average of 11 times in the last year. In terms of workforce participation, full-time employment was reported by 31% of our respondents, 23% reported they were retired, 4% were students, 10% part-time employed, and 19% reported chose not to state their employment status. In terms of absenteeism from work, the respondents reported they missed an average of 11 days off due to their IRD. The most common use of aids and modifications were magnifiers, mobile phone modifications, book alternatives, wire long canes, and screen magnifiers. As Orla and Doug have already referred to earlier, the role of mental health is quite significant in this study. Almost 3/4 of our respondents said that they were affected by anxiety in the last year, approximately 2/3 or 62% with depression, over 1/3 with social isolation and financial stress. And this anxiety and depression was also reported by the adult caregivers of children as well, almost to the same magnitude. So the overall financial analysis here is quite fascinating. I would say is quite a large impact. So when we look at the total cost, at least the lowercase bound, and then look at the number of cases in the US, also the lowercase alternative, the total cost is approximately $73,000 per person for 1 year with an IRD, and that is huge. But to me, what's most interesting is how these costs are distributed. Almost 2/3 of those due to a loss of well-being, almost exclusively due to mental health, anxiety, and depression. And that one of the smallest components of this is to the health system costs themselves, only 3% of that total. And this is quite unlike some other conditions where you see the largest cost drivers of use of medications, for example, or hospitalizations because of complications. That's not the case here with IRDs. So now let me just make a few comments about the results themselves for some context. Wanted to say that the prevalence of RP, Stargardt, and Usher syndrome among our respondents from our survey matches almost exactly the overall composition in our registry as a whole. I wanted to note too, while we're all gathered today, this survey was live during the start of this months long now and running COVID-19 pandemic. So it's difficult to say at this moment what the impact of COVID at that moment in time was on employment or non-response about the employment status. I wanted to note too that 77% of our respondents had reported a genetic test within the last 2 years, likely reflects the fact that we sampled from our registry, which has grown in size due to the genetic testing study that we have sponsored for the last few years since 2017. I wanted to make just a note about one of the limitations of the study. The authors of the report point out that one limitation is we are relying on our specific survey sample and our respondents. And our particular sample and those who chose to respond to it might have biased the study in certain ways. For example, maybe our survey respondents were more likely than those who did not respond to respond to the survey because their IRD had significantly impacted their lives. So this overrepresentation in the sample could make the impact of mental health higher than it really is in the population overall. But I think we saw from Orla's presentation that in fact those results are quite consistent across the 3 regions where this type of study has been conducted by RI. Now I wanted to have just a few final thoughts before closing and passing the microphone on. That is to say, this cost per person of $73,000 is a very large number. And to me, the most striking result of this study is that the largest component of the cost is on well-being. And for some conditions, the greatest costs are attributable to those things that are incurred by the healthcare system. At the Foundation Fighting Blindness, we are dedicated to funding research towards treatments and cures for the IRDs. And I think we typically think about what that means. We're thinking of restoring some lost vision, maybe, or slowing or halting the progression of worsening vision. But we know that that loss in vision is connected to real world impacts like activities of daily living, navigating to your job, choosing maybe not to go to an unfamiliar place in the evening with your friends, maybe difficulty preparing your meals, sometimes difficulty seeing your family member's face across the room, any number of these real world impacts. But I think what this raises to me, this study really surfaces, is that the loss of vision has a significant impact on overall well-being, especially from anxiety and depression. So as we think about this study, we need to communicate the importance of our mission and its urgency, not just because of the difficulties associated with a loss of vision, but because of that part that we don't often see, but is so apparent in this study, and that is the huge toll of mental health. And so I believe this burden is so high, it's going to help us in our efforts to raise funds for research and advocate with others like Fighting Blindness Canada for policies around employment and support services. We're thrilled about the product pipeline. It is so vibrant today compared to just a few years ago. And we really view this as a real source of hope for everyone who is affected by an IRD. Thank you for attending this webinar today, and thank you to the members of our registry who responded to the survey. Thank you.
Thank you so much, Todd, and for drilling down into some of the complexities in these studies. It's clear that the scale of data really is as broad as it is deep, so thank you very much. Next up, we have Allison Galloway. So Allison is the proud mother of 2 children, Logan, age 9, and Zoe, age 7, who both have been diagnosed with Leber's congenital amaurosis 13, or RDH 12. Allison is a nurse practitioner, surgical assistant, and master's prepared nutritionist. She lives with her 2 children and husband in Westminster, Colorado. We are very grateful to Allison for carving out time in her active schedule to be with us today. So without further ado, Allison, take it away.
Hi there, can you hear me? Can you guys hear me?
Yes, we can hear you,
Okay.
Allison.
Perfect. Okay. Thank you for that introduction. And I apologize for not being live on video. I'm at work today in my office, and there are people running all around my office. And I figured I'd spare you guys from watching the chaos as I sat here. So instead, you get to look at my cute little family on the screen here while I chat. Again, my name's Allison Galloway, and I have 2 children that were diagnosed with Leber's congenital amaurosis. My son Logan is 9, and my daughter Zoe is 7. When my children were first diagnosed, I went through all the stages that everyone expects of grief and anger and fear. You start making up stories for how your kids' lives are, not going to be what you thought they were going to be. You lose dreams of having what we say, quote unquote, normal children and having a normal life. The stories you make up are, oh, my kids aren't ever going to go to college. They're not going to be able to play activities. They're never going to be able to leave the home or be out on their own and be independent. They're not going to have jobs because, the first thing I saw when my son was 3 and diagnosed was the unemployment rate of people with IRDs was like 75 or 80%. Then you get worried about, God, I'm never gonna be able to retire. I'm gonna have 2 kids in my house forever. It wasn't the forefront of my thinking, but it was definitely always a storyline in the back of my head when they were diagnosed. The financial burden of the disease and how my family was gonna struggle with this. As was said, we live in Colorado. Fortunately, we are considered an upper middle class family out here, and we have great family and friends and support. So I can't speak for those who have lesser means without the support system we have, but I shudder to think about the burden that it places on them, because the burden is huge on us. And we are of a different, our economic status is different. We've had to pay for a lot of our own doctor's visits. We have insurance here in the US that we have a pretty large deductible, and they don't like to cover too much for us, so we pay out of pocket for a lot of the stuff, and we've always been able to pay it. We were told when our kids were first diagnosed that there was nothing we could do for them, that we should just accept it and move on. As a provider, I did not accept that. That wasn't even remotely a possibility for my family. So I fought hard to find the best doctors. Here in Colorado, we failed finding the best doctors. We struggled with a lot of bad care. And finally, we found some amazing doctors in Iowa and Pennsylvania. So through our own dime, we flew out to Iowa, we flew to Pennsylvania, we saw the best doctors we could to get the correct diagnosis and multiple opinions. And I can't imagine for those families without the funds to be able to do that. They get the diagnosis and they just accept the defeat and move on. Had we not been able to do that, my kids, I probably would not even have the genetic diagnosis yet, because back here in Colorado, they said there's really no point in getting the genetic testing because there aren't any cures for it. And if, for families that are living paycheck to paycheck, they go, okay, I can't go fly somewhere and push it and go see more doctors and specialists because it's not a cheap adventure. We've been very discriminated against in situations like schools. My son Logan was offered a spot in a prestigious gifted school for elementary, but they soon then changed their minds about his acceptance as they informed me they could not afford to financially provide the support he needed through a vision teacher, and it would cost the district too much. So because of the funds of the district, my son couldn't go to that school. It was definitely a punch in the gut, and I definitely felt discriminated against, and the mama bear in me was ready to attack, but we luckily ended up at our local public school, and it turned out to be the best possible fit. We're lucky here, at least in Colorado, and from what I've heard from other friends and family, that in the US, our schools provide vision teachers for our children at no cost to us except for our taxes. They're taught Braille in school. They get mobility every week. They have assisted devices given to them. I mean, my kids have so many laptops right now that when they come home from school, I swear they have like 10 bricks in their backpacks. And again, it's no cost to us except for our taxes, but I know this isn't true everywhere. We feel very spoiled, but we're aware of many others that just don't have this luck. We were lucky enough early on in the diagnosis of my kids to find an amazing group of people through the internet and social media that have the same diagnosis as my kids. Together, we formed a group called RDH12 Fun for Sight. We support each other and help push research for our very rare gene. My kid's gene is super rare in the realm of LCA. There are probably only about 200 people in the US with their diagnosis. One of the families that is in our group, we're international. We are all over the place. One of the families in our group lives in Cyprus, and I was talking to the mom, and she was telling me how her daughter is not learning any Braille, and she's 10 years old. And the reason is because the burden is too great financially. They live on Cyprus and the island, and they'd have to go after school on a 1-hour ferry ride to a teacher off the island for a 30-minute visit, and then they'd have to get back what they have to pay for financially. Then they'd have to get back on a ferry for an hour back home. And with work and other children that they have, they can't do it. So she's just not even learning Braille, which is, I think, in my opinion, so important. I mean, without it, my kids would be struggling so much right now. We also have some stories in our group, a family back in Pennsylvania that had to move because that's the only way they could get their teenage daughter into the right high school so that she could have vision instruction and the proper care. So they had to leave their house of 20 years and move just so they could get their daughter into a school that would give her what she needed. The financial burden is just so strong, and just talking to all the fellow people in our group, everyone has a story about the challenges with having children that have vision issues. In reading the study that was done here, I was happy to see that the mental state of kids with IRDs and caretakers was being discussed, something we don't usually talk about. My children, at this point, we have decided that we want them to see a therapist at least quarterly because of the stress and the anxiety that can build up with this diagnosis. And I don't, many of you may know, it is not cheap to get therapy. It's about $150 an hour per kid. So we have to self-pay for that. Our biggest fear is the mental state of our kids with such high rates of depression and anxiety in those people with IRDs. School is hard enough for kids with bullying and cliques. Imagine being the blind kid and the impact of that. Just yesterday, my son came home saying he hates recess because the other kids all play visual things and he can't play. So he sits out there by himself. And then, of course, I sat down with him and I talked to him about strategies and how we can get him playing with other kids. And so, of course, he then went this was 2 days ago. Yesterday, he went back out and asked these kids if he could play tetherball with them. And these fourth graders said, "You're blind, you can't do that." And my son came home so upset. And I fight back tears as he tells me this stuff. So in my opinion, a therapist is a mandatory thing for anyone diagnosed with a disease such as my kids have. And as parents and caretakers, the guilt and the fear and the struggles that we have, the grief we have, I think it's vital for us to also have the therapy and other people supporting us. And it is not cheap at all to do it. So if you're not financially able, the burden is just immense, or you just don't do it and you struggle. We were told that we could apply for Medicaid here in the United States for our children, but we've decided not to, as we can currently support our own healthcare. But the burden on our system for those with visual impairments, it's substantial. So many are on Medicaid and Medicare, and it's just getting harder and harder, especially with our economics and politics going on currently in our world. As I said before, one of our fears for our kids is unemployment. I know every parent thinks their child's a genius, but mine really is. No, I'm just kidding. My son is amazing, though. He has an amazing memory. His math and verbal skills are off the charts. He's determined at this point to develop a product line of robot vacuums. He's actually in talks with iRobot in Massachusetts. They make the Roomba robot vacuums. And he's actually helping them make STEM and coding robots that are accessible, as they are not right now. We've tried so many programs to get him into programs, and we've been turned away by so many companies. And he hasn't been able to learn how to do coding and all these things he has such a passion for. And he has fallen in love with robot vacuums. And believe it or not, iRobot has really, they have been amazing with him, and he's so excited. But, you would think he has such a bright future because he has this brain for robots and robotics and pushes through, but does he? Can he get a job he wants? Does he have to move so wherever he works, he can be close so he can get there, because he can't just live anywhere and drive a car to work like the rest of us do? He's brilliant in math, but comes home every day saying how he's struggling because he can't write the math problem down and do math like everyone else. Will he be able to meet his potential? We tell him every day that he can, and he can do everything, even though sometimes I struggle to believe it myself. The fear that he'll not be able to support himself financially and fall into the terrifyingly high rate of unemployment that this study and others like it have so often pointed out, it's overwhelming. The group that I referred to before that we were part of, the RDH12 group, we decided early on that we're not going to sit back and wait for a cure. We know that money is what stands in the way of a cure for our children. Because of this, we formed a 501c3, started fundraising and seeking out scientists that could help us. My kid's particular gene defect, like I said, is particularly rare. So no pharmaceutical company will ever fund us because they won't make any money off of us. So they have no motivation. Each year I put on a fundraising race called the I Love Logan and Zoe 5K, an auction. It's in the 25th hour of my life. Each day I work on it. We've raised over 40,000 each year to support research. We know that the financial burden is on us as families to fight for research because it's not going to get done otherwise. Unless the foundation has been amazing and they've helped us out, but there's so many genes to work on. And of course, every parent wants their gene worked on and done yesterday. So we've had many ups and downs in this journey to find a cure. I can only hope that this great study that Retina International and the foundation have presented to us convinces people that the cost of a cure, although very expensive, far outweighs the burden of these diseases. If more funding was put into research, we would not only decrease the financial burden, but we'd also create a brighter future for those who are slowly losing their sight, like my kids. We've been told numerous times that a cure for my kids would be a slam dunk since it so closely resembles the RPE65 gene mutation that Luxturna helps with. So our question is always, why is money what stands in our way of this? We fight it every day. I've said many times before, and I'll say it again, that this rare disease is what comes between my children and the world. It limits them. It's flipped our world upside down and forever changed all of us. It keeps us on our toes, constantly looking for an answer and fighting for our family. The quality of life changes for all of us are palpable. And as Doug had pointed out in his talk, COVID has made things even more challenging. My kids were homeschooled in the beginning of this semester, and I'm still trying to figure out how you homeschool children with blindness. I'm an essential worker as a practitioner, and my husband was never able to stop working. And I had to cut back on hours during that time to try to sit with my kids and help them do their online learning because they can't do it. They can't see the prompts. They can't see the games. It was very stressful, to say the least. And we even had our school, our vision teachers were fighting to get with our children to help them. And I actually had the district say to me, well, they can just teach the kids Braille online. And I challenged them and said, how is that even possible? And so it's a constant battle. It's a constant struggle to try to get the kids what they need and what they deserve so they can reach their potential. We'll never give up on our children. We'll never stop fighting for their well-being. All we want is for our children to not have to fight so hard, to just simply be. Thank you.
Thank you so much, Allison, for sharing your moving story in such an open and honest way with us. I'm sure we all agree that here today that keeping the patient voice and experience front and center throughout our search for new therapies and additional supports is vital to our success. We wish Logan, Zoe, and your family every success in the future. We are moving on to our final speaker now, and this is just a reminder that anyone who wishes to participate in the Q&A following this presentation, please email your question to registration@retina-international.org. Finally, I am delighted to welcome Dr. Rob Koenekoop from Montreal Children's Hospital. Rob is the principal investigator for 7 human clinical trials to test new drugs, genes, genetic methods, and all other modalities to combat blindness due to photoreceptor diseases. At McGill University, he is currently Professor of Pediatric Surgery, Human Genetics, and Adult Ophthalmology. I'm sure we are all very eager to hear your take, Rob. Over to you.
Thank you, Fiona. I'll just wait for my slides. Thank you, Fiona, very much for the introduction. Thank you very much, Retina International, for this invitation to participate both in the panel. I'll give a little talk and then I'm very available for questions. I'm a clinician scientist at the Montreal Children's Hospital. I work very closely with Doug and other vision scientists across Canada. Doug and the Fighting Blindness Canada have supported my career for 25 years, and I'm very, very thankful for that. Without that, we just couldn't do our work. So my perspectives about IRDs comes mostly from 25 years of experience taking care of 6,000 IRD patients in Canada. But my perspectives are also coming from having done or still doing research in genetic discovery. And now more recently, I'm putting all my efforts into therapeutics. So for this little talk that I have, I would like to just mention a few highlights. Thank you very much to my panel members for laying the groundwork for my talk. The next slide. So as an introduction and a preamble to my part of the talk is that improving vision and arresting photoreceptor death are major unmet medical needs for 4 million IRD patients around the world. Now, just historically, I think one of the reasons that we are here today and at this point in our journey to treat IRDs and to understand them is because of the convergence of 3 revolutions at the same time that are coming together to make all this possible. Number one, my major point is that the genetic revolution has thus far delivered us 270 retinal genes. The imaging revolution has allowed us for the first time to see and count photoreceptors. And the therapeutic revolution has discovered that dormant cells can be living in degenerating retinas. Next slide. The genetic revolution started in around 1990. And today in 2020, we have over 270 genes, each telling its own story about what goes on in the retina when it works properly and when it doesn't. FYI, RPE65 was discovered around here, and RDH12 was discovered around here. So we still have work to do, but this is an incredible revolution. Next. The next revolution that is helping us bring treatments to IRDs is the imaging revolution and the testing revolution. Here's an example of an OCT where you can see live photoreceptors, live RPE cells, and here's adaptive optics where you can actually count the number of cones. This is not limited to imaging, as I said, it's also the introduction of full field sensitivity testing, rod mapping, and other much more representative testing devices and methods to show safety and efficacy in trials. It turns out that the old-fashioned testing methods that we use, acuity and field and ERG, are not as friendly and helpful, but these new methods are. Next slide. This is an example, just one of them, about what we're doing now. We are able to, on our left, do gene therapy to improve retinal sensitivity. And on the right, we have drugs that can do the same thing. Next slide. So one of the major things that I wanted to point out is that we're in the middle of a revolution, things coming together, and now we're going to move forward very fast. But the other point that I wanted to make for this discussion and answer questions about in the final panel is that genetic testing is absolutely crucial. So Allison, I was very disturbed to hear that some people told you that it's not helpful. So let me just summarize why it's so crucial. And it's a game changer for families and kids with IRDs. A genetic diagnosis settles the diagnosis at the molecular level, thus confirming the clinical diagnosis. This is not an easy area for ophthalmologists and retina specialists and pediatricians. This is a difficult area diagnostically. So having the diagnosis genetically confirms it. It also eliminates the possibility of diseases that mimic IRDs, like autoimmune diseases, trauma, infections. These are called phenocopies. It's very important to settle the diagnosis, but it's also very important to eliminate other diagnoses that look the same. I'll come back to that later. And one of the points that we don't speak about enough, and that's why I wanted to bring it up today, is that just this fact alone, getting the genetic diagnosis, gives relief to the patients and to the families for many reasons that we can go into later. But it's definitely, without any therapeutic implications or family planning implications, which we'll get into in a moment, the genetic testing result gives relief. Next slide. So more key reasons to do genetic testing is that it settles the inheritance pattern, because one mutation would be an autosomal dominant disease, 2 mutations is recessive. And if the mutation is on the X chromosome, then it's X-linked recessive. And this has huge implications in family planning. It does help with family planning in other ways as well, because sometimes the genetic testing result tells you that there's no transmission possibilities, or that it can be 25% or even 50%. So family planning. It also helps very much with school planning, because some kids will be able to go to regular school. Some genes are just very slowly progressive and very mild. Other genes have a more substantial impact, and the children should go to schools for the blind with low vision aids. Genetic testing helps with professional employment choices. It helps because it helps future visual loss and progression. Next slide. And maybe the most exciting reason, but certainly not the only reason, is to do genetic testing is it allows patients entry into gene-specific treatment trials. Even if a gene is not necessary for entry, it may be that certain genotypes respond better or worse to the drugs, to the stem cell treatments. So this would influence future trials. So genetic testing is crucial for this reason. Knowing the gene also allows the trial to filter out the patients who have phenocopies of IRDs. They should not go into these trials. They will not get better. Next slide. So the IRD's disease costs have been very well discussed from my panel members. My quick division of costs highlights the fact that there's costs at home with extra lighting, etc., and talking emails, at school because of extra help, Braille, shadowing programs, at work because of extra protection, etc. We should also talk about transportation, clinic visits, and low vision aids and rehabilitation. Last slide. What's another reason that things are coming together is that the treatments that we are working on and that have now come forward, either in a phase 3 trial or acceptance by the FDA, EMA, and now Health Canada, showing efficacy and safety. But there's another advantage, and that is that in the first study, economic study by Johnson et al. Last year, studying the cost effectiveness of Luxturna versus standard of care for patients with RP65 mutations, they calculated that the cost was lower after Luxturna, $2.2 million, versus standard of care being $2.8 million. So this is just one study of 70 patients who were given the therapy or standard of care. The other exciting thing is that there was a much higher quality of life calculation for Luxturna at 18 versus 8.6. So it is a day to be celebrating the efficacy and safety and economic improvements of our new therapies. So I'll end it there. Thank you again for allowing me to participate. I'm looking forward to the questions and answers.
Thank you, Rob. That's brilliant. So we will now commence with our Q&A session. Thank you to everyone who has submitted your questions. This is just a final reminder that if you wish to do so, please email registration@retina-international.org. And Orla, without further ado, I hand back to you.
Thank you, Fiona, and thank you to all of the panelists. You know, I was scribbling down questions like crazy as you're all speaking, but to be fair to those who have been listening in, I will go to all of their questions first. There have been a large number of questions have come in around the content of the reports. So I might just quickly and easily answer those first. So to all of you listening, yes, there is a breakdown of the demographic data of the survey participants for each of the studies. Yes, age, gender, and whether the individuals are parents or patients has been included. I can also tell you that there is a breakdown of each condition and cost type by condition that is listed as well. So that is all included in the reports. Further detail with respect to the survey results, so I can tell you that in Appendix C of both reports, there's the full layout of the surveys and the responses for each country. So that data is all there and available to you. With respect to the questions that come in relation to the genetic testing data, we do 100% acknowledge and appreciate that the respondents are a special sample, if you like. They have been engaging with us through patient organisations, so they are individuals who are already engaged, and indeed they are individuals who have access to IT, who are able to communicate and respond to the survey through their laptop, phones, PCs, tablets, etc. Questions then have come in relation to the timing of the genetic tests, and there is a breakdown of that in the reports. And the reports do indicate how long ago it was since individuals have received their genetic test. And I think there was one other based on the content. Yes, so with respect to costs relating to falls or driving accidents, yes, there is data in relation to falls in each of the reports, but not specifically to driving accidents. That's a very precise query there coming in from one of our listeners. I'm going to then combine some of the other questions that have come in because they are quite similar. And one of the things that have come up across 3 questions is really and truly, people want to know is, do politicians, decision makers and government bodies hear our voice? Do they listen to the patient voice? And do they or would they listen to the results that are found in a study like this cost of illness study? So I suppose someone who has actually been very active in this with a fantastic and successful campaign is Doug. And Doug, I might give that question to you.
Sure, I'm happy to address the question. I've had the privilege of speaking with a number of our premiers, the health minister in Canada, and very much they are interested. They want to know, they want to understand what it means living with an inherited blinding retinal disease, a blinding eye disease. They in different cases they can point to someone they know that has been living with a blinding eye disease. So it really does speak to them. What I was quite gratified was the level of detail that resulted from our submission to the body that's going to give a recommendation or not to the provincial governments in Canada. They had extensive, detailed questions of our submission that we put together in surveying those 537 members of our community and with our vision partners in Canada. And it was very, very detailed questions. So the value of giving voice of a survey like this, putting a number when there was not a number before, is very helpful in giving and answering questions, especially with the policy advisors and analysts. They count on that really validated information. for the politicians, it is the storytelling. So having voices like Allison speak up and tell their story. The case study that we did in our submission to the government agency really was impactful. And with the announcement from Health Canada that the first inherited retinal disease treatment is now available in Canada, you know, we had amazing stories on CTV, on global TV, where people living with these conditions were telling their story. And it had just an amazing outpouring of support from Canadians as to the importance and the facts.
Thank you, Doug. And I suppose this individual who has followed up with a second question, and I'm not sure what country they're from, but Todd, could you give an account of whether that's a similar situation in the US?
Well, I can certainly say that we have individuals who are associated with the foundation who are lobbying and who are talking to policymakers about research towards ophthalmology eye research. Certainly from my understanding and background in health policy, having data available is better than not having data available, and Doug referred to that. And one of the things this study allows us to do now is to say, compare the cost of illness attributed to the IRDs to cost of illness due to other diseases. So that as we go to advocate for funding for our particular concerns, that we can hold that up against other cost of illness studies to say, we'd also like consideration for funding. So I think that's a key part, is the data is very important.
And I think it was touched on earlier that all of the challenges and issues that present to the vision community have in fact been exacerbated by COVID-19. And I think now more than ever that the patient voice needs to be quite prominent and make sure that it's actually heard, because all of the issues around navigation, mobility, equity and online access, you know, they were challenges before and they're just worse now. So I think that's something that definitely needs to be in the forefront of everyone's mind, and particularly our governments and our policymakers. I'm going to move to some of the other questions that have come in. And, you know, we are excited, of course, about some of the recent approvals in various countries, but one question has come in around the concern around how prepared the clinic is to handle the onslaught of new therapies. Should they all be successful? Are people going to be trained? Is there policies and programs in place in the clinic to help with getting the clinicians trained up and to carry out this procedure? And is there any idea of how long that would take once approved and once access is given the green light? You know, what happens next? So Rob, I might pass that over to you.
With pleasure. Great question. So this is partly our responsibility. People like Doug and I and other vision researchers across North America, we also teach residents, we teach nurses, we teach medical students. It's our privilege and duty to explain to the next generation that this is the new ophthalmology. We cannot turn back. We don't want to, but we cannot. So this is an exciting time, and it's our duty to bring that forward. Not policymakers, of course, hospital administrations, of course, but also to students to enter the field. And what we'll see, because retina is already a very popular specialty in ophthalmology. We'll see people coming into the IRD world. And so, yes, there will be a small adjustment, but we're very prepared for the extra patients. We are seeing more patients with IRDs than ever before, because one of the things that we've learned to do is to speak to patients over the phone. So, and by Zoom. So I've prepared a handout that I email to them, and then I call the patient. So I'm calling more patients now than ever, and it's not taking any more of my time. So we're adjusting, teaching, reaching out to patients in a different way. I don't see any problems with more patients coming in, because it's not just going to be Luxturna for RP65. I predict that very soon other genes are coming as well. There's now a pipeline that we've created with RP65 that took 27 years from discovery to Health Canada approval. But that pipeline is now ready to go. That pipeline is going to be streamlined.
Orla, if I could just jump in here, I think also to help the clinics, Todd and myself have mentioned the importance of genetic testing. So people living with an inherited retinal disease, whether it's through my Retina Tracker or in Canada with the Fighting Blindness Canada's patient registry, getting your genetic test will help triage your care. And it will help inspire researchers like Dr. Koenekoop in order to develop those new treatments that we know are just around the corner. And you know, in order to help that, Fighting Blindness Canada has done step-by-step guides for every region and province in Canada, so that you can do step 1, step 2, step 3 to get your genetic test, and that will help on the other side, getting the clinics organized to work with people that have the treatment options, or as we're so proud working with Dr. Koenekoop and his colleagues to have clinical trials available in Canada and be able to notify you of those clinical trials through our patient registry so that you can access those treatments as quickly as possible.
That's very helpful. I'm just quite conscious, Allison, actually quite a number of questions have come in for you. And as a parent, this person is saying that they assume your children will be more independent when they grow older. However, right now, since they require a lot of your attention, how as a caregiver are you taking care of yourself while also looking after your family? And there's a number of similar comments to that effect as well. So a lot of parents, don't often get this opportunity to engage. So we're very delighted to have you here. And if you could give us some insight and inspiration, that would be most welcome.
That's a good question, and I wish I had a good answer. I don't, God, I wish I had more hours in the day to actually take care of myself. I mean, any mom, any dad will say your kids are what your life circles around. I mean, my kids are the light of my life. Everything I do is around them. And I mean, it's hard sometimes, especially when fundraising time comes around in August.
It's just
possible. Can you hear me?
Yes.
Okay. It's hard around fundraising time because it's like my 5th job to do the fundraiser. But my kids have gotten so used to it and they actually are helping now. And so it's not easy. I think any parent, even for kids without vision issues, it's hard to find time as a parent for yourself. It should be a priority. I do think that therapy is super important for parents and for patients. The one thing my husband and I did learn upon the diagnosis of my kids is that we handled it very, very differently. And sometimes when a diagnosis or something occurs, it can either bring you together or tear you apart. We know a lot of families that have divorced after years of dealing with a child's sickness or illness, whether it be retinal or anything else, because it is hard. You deal with it very differently. My husband is able to separate it out, and I know he thinks about it and loves my kids, but for me, being a female, I like to say men are kind of waffles. You're able to compartmentalize, an issue here and there and deal with it one at a time. And we women are kind of like spaghetti, where we're constantly trying to do everything at once, whether that's good or bad, I don't know. And my husband and I have just learned that we deal with things very differently. And therapy has actually helped us through that. But But I don't know, if I ever figure out that self-care for myself thing, I'll let you know.
That's brilliant. I think that leads into one of the other questions that has come up, in that, you know, and I suppose this goes to all of you, and I might start off with Rob and work my way around the screen, but were the well-being results a surprise to you? And do we actually need to consider about packaging a care team for those individuals and families who find themselves with an IRD diagnosis? And the example that's given is, you know, for the diabetic population, someone who's diagnosed with diabetes will have an endocrinologist, will have a podiatrist, will have an ophthalmologist. You know, this team and this network that they can liaise with, and those who can liaise with each other about the individual and the family affected. Is that something that we should maybe start to consider for the IRD population? Or is that something that's even possible? Or again, is that just adding to the workload? Rob, what do you think?
I'd love to start with that question. Number one, I was so pleased with the data that has been generated by this analysis and by this report and research. But I must say I was a bit shocked. I've been following and managing IRD patients for 25 years, and I know about their schooling and their suffering and their burdens and their costs. And I still was shocked at how high the costs are and how little of the burden is removed by the governmental systems. So I think it's very powerful data that it's now our responsibility to bring this forward and to almost advertise this data to the policymakers, because it'll be easier for them also to argue that these treatments are not just efficacious and safe, but they're also economically viable. The second point is very important, and I think that we need to do a little bit more work here. As we quickly discussed before we started, it's very well established that certain types of patients, like diabetic patients, have a team of doctors surrounding them, and IRD specialists and IRD patients should have the same. I'll give you an example. Because I'm focusing so much on the genetic testing and the research and bringing the treatments forward, I do not have as much time as I should to make sure that the patients go to the low vision clinics or rehabilitation clinics. And so that's number one. But number two is I'm a pediatric ophthalmologist who knows a lot about IRDs, but for instance, I know less about glaucoma, and I don't do cataract surgery. So there needs to be another ophthalmologist or optometrist taking care of those parts of the eye. And so, yes, very much so, IRD patients need a team of at least 4 or 5 specialists surrounding them, including maybe the most important person is a psychologist, a counselor, a social worker, or even a psychiatrist, because as we are all aware, and it's been very clear from the report also that was presented today, that mental illness, anxiety, depression, suicidality have to be addressed by specialists, not by the ophthalmologist. But it's my duty, for instance, now that this report is so clear, to make a team of doctors surrounding IRD patients, but it will require a countrywide, a continent-wide effort to do the same in North America and in Europe.
Absolutely, absolutely. And I think, you know, I am conscious of time, but I would just like to give Todd and Doug and Allison again, just maybe the opportunity to comment on this potential approach. Todd, I'll come to you next.
Well, yeah, I think it's easy to agree with the approach. I think I just wanted to add one more angle from the side of an advocacy and research funding organization like ours, and that is many of us interact with affected individuals like Allison and her family who have become engaged to be part of their solution. But what this study tells me very clearly is that for every Galloway family, there are many, many more people affected by IRDs who are struggling in the background and who choose not to or can't be engaged the way the Galloway family is. So to me, that's a major result of this study.
Absolutely. And, again, I have to say thank you to Allison for finding the time to participate and to join. And, Doug, in Canada is, we've heard from Rob, and, obviously to implement something like a care team, we would be encouraging the patient organizations to promote this.
If I could add just, Orla, I mean, one of the key points of this study, of course, is the well-being, where 2/3 of the costs are identified as related to this. And I think it was no more evident than during the COVID experience, especially early on. Fighting Blindness Canada has a health information line, so you can call toll-free. You can send at healthinfo@fightingblindness.ca your questions. And we were getting lots of questions around COVID and your eye health, and with canceled appointments and surgeries, and what to do, how to navigate and protect yourself from the virus. Also keep your eyesight with those critical treatments, especially for AMD and other glaucoma. But very quickly, the questions turned to mental illness, depression, anxiety, social isolation. So we put right on our website, right on the banner, frequently asked questions and different strategies, coping mechanisms to help. But it is very much an integrated care approach needed in the clinic and outside of the clinic, with organizations providing information to help people improve their quality of life, improve their mental wellness. And we really need to redouble our efforts, and IRDCounts definitely reinforced why.
Absolutely, absolutely. Allison, I'll come to you and give you the last word. I think an awful lot of questions have come through, and really want to deep dive into other aspects of the cost of illness studies. But to finish up today, Allison, what advice would you give to families who do not have a treatment option available to them at the moment, but they want to contribute to research in some shape, way, or form? What advice would you give to them?
Yeah, I mean, first I want to say I unfortunately wasn't surprised by the results of the mental health study, because I mean, we live it every day in my house, and it's not easy being diagnosed. It's not easy being the person diagnosed, because I see it in my kids' eyes, and it's not easy being the parent of someone who is diagnosed, because we have the guilt and everything that goes along with it. As far as the best thing, my recommendations for parents is, I'm not a social media person anyway. I hate it. My kids are smarter than me with all of it, and they're only 9 and 7. But social media really, getting on the internet, finding other parents or other people that have the same disease. Everyone has pointed out, genetic testing is the most important thing to do. I have met so many, I knew nothing about blindness. I knew nothing about IRDs until my children were diagnosed. And I'm like, all of a sudden became a magnet for all of these people coming out of the woods, like, oh, I have an IRD, or my kids have this, or I know someone. And I give everyone my phone number, my email, and like, call me, because a support group is so vital. So getting out there, finding people that have similar IRDs. I mean, I think the biggest issue with getting a support group is, like diabetes, there's symptoms that go along with it, but diabetes is diabetes. IRDs are very different. Some lose them when they're born. Some don't lose their vision till they're older. Some never lose their vision. They just lose a lot of ability to see, in certain regions of their eyes. So it's very variable. So I found that finding fellow gene partners that have the same gene, we can discuss how are your kids doing, what's happening with them. I can talk to people that have teenagers and be like, okay, what is it going to look like for us in 10 years? So just finding a support group, finding great teachers. There are so many out there. Our vision group, I mean, they have introduced us to so many things. The Foundation Fighting Blindness has been amazing to us. We are associated with the United States Association of Blind Athletes. My kids play hockey with a low vision team. My kids run track and I run along with them, tethered to my son. We did archery just 3 weeks ago. Whoever thought putting an arrow in a blind kid's hand would be a good idea, but it was amazing and my kids loved every second. So, you know, finding just, you have to just research, you got to push, you got to get out there. And there's so many groups out there that are looking to give your kids or yourself all the experiences you can get and the education and the support.
That's a really positive note to end on. I'm sure you'll have noticed that my background has got quite dark here. It was a beautiful sunny day when we started this webinar, but the evening time is coming upon us. Took me by surprise. So Todd, Rob, Allison, Doug, and Fiona, thank you so much for making this webinar possible. For the panelists, to your time, we absolutely appreciate it. I can't tell you the number of questions that are still coming in. So anything that we can address, we will, and anything that we can't, if you don't mind, it would be really helpful to pass it on to you. And Fiona, I'll pass it back to you now.
That's great. Thank you, Orla. So yeah, that brings us to an end of our Q&A session and our panel discussion today. If you have any outstanding questions, we weren't able to get to all of them, but please do keep sending them in and we will forward them on and get to as many as possible. As Orla said, huge thank you to our panel today, to Orla herself for moderating, to Todd, Doug, Allison, and Rob. I think we all share the same sentiment that really brilliant panel and excellent discussions and sentiments were shared today. We'd also like to thank again just our partners on this study, which were Foundation Fighting Blindness Canada, AGTC, Janssen Global, and Novartis Pharma AG. And of course, a final thank you to all of you for your attention and participation today. We hope you enjoyed it and look forward to welcoming you to another Retina International event very soon. Until then, thank you and goodbye.
Thank you. See you all again soon, hopefully.